I'm Masamitsu Hyodo. I'm from Department of Otolaryngology, Kochi Medical School, Japan. Today, I'm talking about a series of clinical studies on spasmodic dysphonia in Japan. At first, I would like to thank the organizing committee to give me an opportunity to talk at this meeting. SD is considered focal laryngeal dystonia, and it's a rare form of functional dysphonia with no organic disorder or paralysis in the phonatory organs. It is characterized by involuntary and intermittent spasms of the intrinsic laryngeal muscles, and classified into adductor, abductor, and mixed SD. The voice quality is strained and strangled with involuntary vocal breaks in adductor SD, and intermittent breathy or aphonic in abductor SD. The SD patients have great difficulty to make smooth conversation to disturb their work or daily life. Here, I show the laryngeal images of phonation and inspiration. During phonation, the bilateral vocal folds keep median position with constant tension. In AD-SD, the vocal folds involuntarily close the glottis tightly, and in AB-SD, the vocal folds open to make the voice breathy. I will show you the typical voice samples. Firstly, adductor SD. The voice is very strained and shows intermittent break.
Ah, ah, Aoi o Aruhi kitakaze to tai o sakura o shimashita tabito no gaito o nugashita hou ga kachi to iu koto ni kimete mazu kaze kara hajimemashita. Kaze wa oshi hitomeguri ni shite yarou to hageshiku fukitaremashita.
Next, abductor SD. The voice shows intermittent breathy hoarseness.
本屋と花屋は通りを隔てて反対側にあります。昔、あるところにジャックという男の子がいました。
To date, there have been clinical issues on SD. SD is considered a rare disease, however, its prevalence has been unclear. Diagnostic criteria have not been established, making diagnosis difficult. Botulinum toxin therapy is a standard treatment for SD, but it has not been approved in most countries, including Japan. So, we conducted a series of clinical researches on SD. First, we conducted a nationwide epidemiological survey of SD in Japan. The methods are shown in this slide. The slide shows the results. For SD type, 93% was adductor type and 6% was abductor type. Mixed type was very rare. For gender, about 81% was female and 20% was male. Female was about 4 times more than male. The slide shows age distribution of the patients. 20s and 30s of their ages were predominant. This means that SD is predominant in younger female. Durations from symptom onset to diagnosis ranged from 1 month to 46 years, with a median value of 3.0 years. More than 21% needed over 10 years until diagnosis. With this survey, we estimated prevalence of SD in Japan. New patients in the 2 years were 887, and total number of patients was estimated as 4,500 to 9,000. This means 3.5 to 7.0 patients per 100,000 in Japan. This slide shows previous epidemiological study of SD. Prevalence from our study is similar to the studies in Rochester, USA and Iceland. Male to female ratio is about 1 to 4 in Japan, and female ratio is relatively higher than in other countries. Mean age of onset is 30s in Japan, similar to those in Rochester, but younger than in other reports. In short summary, we conducted world's largest nationwide survey of SD. SD is predominant in 20s and 30s of ages. Male to female ratio is 1 to 4 in Japan, showing higher percentage of female than in other countries. SD prevalence is 3.5 to 7.0 per 100,000 in Japan, and generally similar to the previous studies. Next, we tried to establish diagnostic criteria. It would contribute to early diagnosis of SD. Its principal concepts are: to extract main symptoms of SD for each type, include helpful subjective and objective findings during phonation, include therapeutic responses, and can be diagnosed by non-experts in laryngology or phonetics. As for diagnostic criteria, we set 5 requirements, such as voice symptoms persist for longer than 6 months, no organic lesions or paralysis, no apparent abnormality in breathing or swallowing, no apparent physical or psychological event prior to the onset, and no neurological or muscular disease except for dystonia. We listed up 4 characteristic voice symptoms in AD-SD and AB-SD each. For example, in AD-SD, they are involuntary and intermittent strained or strangled voice, involuntary and intermittent voice break, a periodic voice tremor, and effortful phonation. Accompanying symptoms include voice symptoms that can be references for differential diagnosis. For example, AD-SD patients have difficulty to speak words which begin with a vowel. On the other hand, AB-SD patients have difficulty to speak unvoiced consonants. Objective findings during phonation are listed, that include laryngoscopic finding, laryngeal or cervical abnormal movement, and sensory trick. Treatment response includes effectiveness of botulinum toxin and insufficient improvement by voice therapy. Differential diagnosis includes essential or secondary voice tremor, muscle tension dysphonia, psychogenic dysphonia, and stuttering. This slide shows voice characteristics of each disease. Based on these symptoms of findings, definite and possible diagnosis were made as shown in the table. Definite diagnosis is obtained by meeting 3 or more main symptoms and 3 or more accompanying symptoms or findings during phonation. We created diagnostic criteria and severity grade of SD. They included both objective and subjective symptoms and findings. They will contribute to early diagnosis and objective severity assessment, and treatment selection of SD. Treatments for SD include voice therapy, surgical therapy, and botulinum toxin injection into the laryngeal muscles. Of these, botulinum toxin therapy is globally considered a standard therapy. We show the pre- and post-treatment voice. Firstly, before the therapy, botulinum toxin therapy is globally considered a standard therapy. We show the pre- and post-treatment voice. Firstly, before the therapy.
ある日、北風と太陽が力比べをしました。旅人の街灯を脱がせた方が勝ちということに決めて、まず風から始めました。風は、よし、一めくりにしてやろうと激しく吹き立てました。ある日、北風と太陽が力比べをしました。旅人の街灯を脱がせた方が勝ちということに決めて、まず風から始めました。風は、よーし、一めくりにしてやろうと激しく吹き立てました。
Botulinum toxin therapy for SD was first performed by Blitzer in 1984. After that, there are many reports its effectiveness with over 90% of efficacy rate, and 10 to 15 weeks of duration period. Trong only reported double-blinded randomized controlled study in 1991, and showed improvement of voice parameters after botulinum toxin injection. But, there are some clinical issues in botulinum toxin therapy. It is not officially approved for SD in the most countries, and there is little objective evidence of efficacy. So, we conducted randomized double-blinded clinical trial. The study design were placebo-controlled, randomized, double-blinded study and subsequent open-label study for AD-SD, and open-label study for AB-SD. Primary endpoint was change value of aberrant mora. Secondary endpoints were change values of Grubus scale, voice handicap index, and visual analog scale. This is a study design. In adductor SD, after obtaining consent, the patients were randomly assigned each of BTX or placebo group. In AB-SD, the study was conducted by an open label, because AB-SD is very rare. In Japanese, mora refers to a minimum rhythmic sound unit phonemes. Japanese words are composed of mori, analogous to syllables in English, and phonatory disorder in SD is characterized by aberrant mora. The patients were asked to read the standardized sentence aloud, which contains 25 mori. Phoniatric experts evaluated each mora as normal or aberrant and counted the numbers of aberrant mori. Grubus scale is objective evaluation of disordered voice characteristics. It indicates grade, roughness, breathiness, asthenia and strain. AD-SD is characterized by higher score of S, and AB-SD is by higher score of B. VHI is a subjective scale to rate the severity of verbal impairment. It includes 30 questions. The more severe the subjective voice disorder is, the higher the total score becomes. This table shows demographics of the subjects. There was no significant difference between BTX and placebo groups. I show the results. Change value of aberrant mora was significantly greater in botulinum toxin group than in placebo group. The peak of improvement was at 2 weeks after the injection. Change value of S element in GRBAS was significantly greater in botulinum toxin group than in placebo group. The peak of improvement was at 2 weeks after the injection, same as aberrant mori. Change values of voice handicap index are shown. Although improvement of VHI in BTX group was significant from 4 to 12 weeks after the therapy, VHIs at 2 weeks showed insignificant difference. This is because post-treatment temporal hoarseness after botulinum toxin injection inhibited subjective voice improvement. Change values of visual analog scale in botulinum toxin group were larger than those in placebo group from 2 to 12 weeks after the therapy. But the differences were insignificant. In AB-SD, open-label study was performed in 2 subjects, because this type of SD is very rare. In 1 subject, apparent improvement of aberrant mori was not observed. However, in 1 subject, aberrant mori were decreased after the therapy as shown in this slide. Also, therapeutic effect was greater after second and third injections than after first injection. This result supports probable effectiveness of botulinum toxin therapy for AB-SD. For adverse events, breathy hoarseness was frequently observed in 77%, but it was mild in all cases, and resolved in 1 to 4 weeks. The second common A was aspiration when drinking liquids. There was no correlation between age, sex, or disease duration. Aspiration was generally mild and resolved in 1 to 4 weeks. These adverse events reflect therapeutic effect of BTX, and in patients with AS showed better voice improvement. Through these studies, botulinum toxin was officially approved to treat SD in 2018 in Japan. This slide shows advantages and disadvantages of botulinum toxin therapy. For AD-SD, this therapy is a treatment of choice with advantages of high efficacy rate, diagnostic role, less invasion, and applicable for mild patients. However, it needs repeated therapies. In AB-SD, it is the also effective therapy. But, it is technically difficult and efficacy rate is relatively lower than AD-SD. Another treatment option for AD-SD is surgical interventions. Thyroarytenoid myectomy, selective adductor denervation reinnervation surgery, and type 2 thyroplasty have been developed. Although surgical treatments are irreversible and invasive, sustained therapeutic effect can be obtained. Also, lower medical cost than botulinum toxin therapy is advantageous. Therefore, these surgical treatments are gradually becoming popular. This shows our treatment strategy for SD. At first, voice therapy is introduced to reduce effortful phonation manner. After that, in AD-SD, treatment option was selected by severity grade. Botulinum toxin therapy can be indicated to every grade. Surgical therapy can be indicated directly or following botulinum toxin therapy in moderate or severe cases. In AB-SD, botulinum toxin therapy is an only choice of treatment. In summary, we conducted a series of research activities on SD. A nationwide survey revealed the prevalence and disease characteristics of SD. We created diagnostic criteria first in the world. They will contribute to early diagnosis. A multi-center, placebo-controlled, randomized, double-blinded study was conducted, and BTX therapy for SD was officially approved. Thank you for your attention.